presentar al invitado ya. Adelante.
Ok. Bueno, pues colegas, muchísimas gracias por presentarse al seminario del día de hoy del proyecto de COVID-19 que tiene la Universidad Nacional Autónoma de México en aspecto de modelación de la epidemia. Es un placer contar hoy con la presencia de un paisano, además muy distinguido, joven investigador, que es profesor de epidemiología matemática en el departamento de Population Health Sciences en la Escuela de Salud Pública de Georgia State University. Es además, tiene también una afiliación externa es Senior Research Fellow en la división de International Epidemiology y Population Studies del Fogarty International Center, National Institute of Health. Además, antes de llegar a Georgia State, estuvo en la Escuela de Evolución Humana y Cambio Social en la Arizona State University. Es miembro de los comités editoriales de BMC Medicine, BMC Infectious Diseases, Epidemics, Mathematical Biosciences and Engineering, Infectious Disease Modeling, Scientific Reports, Plus One. Tiene varios proyectos de National Science Foundation trabajando precisamente en aspectos de epidemiología. Gerardo se ha distinguido siempre por su alta productividad en asuntos de epidemiología, de modelación matemática, estimación estadística y particularmente en esta pandemia ha tenido trabajos muy distinguidos, mucho del trabajo que se tiene acerca de la distribución de periodos de incubación, rol de los automáticos, por ejemplo, en aquellas épocas del Diamond Princess, el crucero que ustedes recordarán. Gerardo fue coautor de los estudios, altamente citado artículo, entonces es realmente un placer tener a una de las personas que ha contribuido de manera importante para el análisis y estudio de esta enfermedad. Entonces, sin más preámbulo, vamos a empezar el seminario, simplemente como señalaba Isaac, si pueden apagar sus micrófonos, su cámara, para que la transmisión se pueda ejecutar de manera más segura. Y vamos a proceder. La plática va a ser en inglés. Estamos esperando que se unan colegas de Estados Unidos. Y sin más ni más, simplemente Gerardo, por favor, la pantalla y la audiencia es tuya. Muchísimas gracias por venir con nosotros.
Thank you very much, Jorge, Isaac, for organizing this event. I'm very happy to be here and give this presentation. I will focus on some of the methodologies that we have been working on over the last few years on trying to improve epidemic forecasting and now applying those methodologies to forecasting the COVID-19 pandemic, in particular ensemble approaches. So here's the outline for my presentation. As a way of introduction, I will first focus on the characteristics of epidemic growth, the idea of modeling epidemic growth beyond exponential trajectories. And then I will connect that with some more recent work on using multi-scale models to investigate the dynamics and forecasting multimodal or subepidemics as the aggregation of epidemics as the aggregation of multiple subepidemics. And then I will present how we use these subepidemic models and how we connect them to the actual epidemic trajectory data and the applications to COVID-19, specifically to the US, and some examples beyond the United States. And finally, some more statistical methods that we have been working on for multimodal ensemble modeling. So let me get started. This is the slide about the Kermack-McKendrick model, the 1927. I think most of you are familiar with the simple SIR model. I basically just want to emphasize the main assumptions behind this model, the fact that the population is well connected, well mixed, it's homogeneous, every single individual looks the same, behaves the same. The probability that the virus travels across any pair of nodes is the same. And as a consequence, we expect to observe exponential growth in a completely susceptible population when R0 is greater than 1. So this type of model only accepts, in the simplest, at least in the simplest form, accepts exponential growth trajectories. It's a rigid outcome of the model that may not be the best in all of these situations. This type of model can be expanded to include, to incorporate other features, epidemiological features, different behavior across different groups. Here's an example actually for Ebola, where the authors incorporated the role of funerals in the transmission dynamics. But again, the assumption of homogeneous mixing restricts, in a way, the type of epidemic growth scaling that we expect to observe during, at least during the early growth dynamics, and that can be a limitation. So as a consequence, if we use this type of models in the absence of additional information, we expect that the epidemic will continue to grow exponentially fast as long as R0 is greater than 1, right? Which may not be the case all the time, because epidemics are also regulated by contact networks, by behavior changes, and multiple other factors that sometimes are not observed that can influence the early growth dynamics. Here's an example of 3 epidemics that have the same size, but different epidemic growth scaling. They don't grow exponentially fast. They have different epidemic growth scaling. And that specific type of growth scaling could be related to the mode of transmission, right? Some pathogens are spread through the air, through close contact. Some others are only spread through close contact or intimate contact, like Ebola. And we can expect, in those situations, we can expect that the epidemic will tend to grow exponentially fast, slower than exponential. I will show you some examples. Reactive behavior changes also can quickly influence the early growth dynamics. As I said, contact networks, clustering, and other individual level heterogeneities that may not be observed could be playing also a role. Here's, I think, the canonical example of an epidemic that grows exponentially fast, the HIV epidemic. As we know, the HIV virus is spread through intimate contact, through sexual intercourse, injecting drug use. And so that limits, in a way, how quickly the virus can spread in the population, the contact network in which the virus is moving through. In the United States, the HIV/AIDS epidemic followed a cubic polynomial. And indeed, this cubic polynomial holds even when the data is stratified by geographic regions or by ethnic groups, which makes it a very interesting feature. Another example is the Ebola epidemic in West Africa of 2014, 2016. And when we look at the data at the subnational level, you can see that the epidemics grew relatively fast during the first few weeks. And this figure shows the epidemics in log scale on the y-axis. You can see that quickly the epidemic saturated and slowed down, consistent with something that grows more slowly than exponential growth. And at the same time, we can see that the epidemics were not triggered almost simultaneously, which happens in many other situations, but actually it looks like a wave of disease that is moving or traveling through the population of in this case, Guinea. Okay, so we are seeing asynchronous local exponential epidemics. Here's what we think is the reconstructed Ebola transmission tree of the early dynamics back in the town of Ekedu in Guinea, where we can see that the virus was moving through caretakers, family members, relatives, and healthcare personnel that was taking care of the patients in clinics. So really the virus was not moving in the population at large through the air, which is the case of other pathogens, respiratory pathogens, including the influenza and COVID-19. And so the next step is to, once we recognize that epidemics may follow different epidemic growth scaling, how do we measure that epidemic growth scaling? The generalized growth model allows us to do that quantification. This is a simple elaboration of the Malthus model, as you can see here, adding the P parameter, what we call growth scaling or deceleration of growth parameter, can help us quantify not only the growth rate, but also the growth scaling. If P equals 1, right, we go back to the Malthus equation, the exponential growth model. But if P is less than 1, then the epidemic is growing sub-exponentially fast. And it is of interest to measure the uncertainty on that parameter as well, which is influenced by the amount of data that we have related to the early growth of the epidemics. So we have measured this parameter P across a number of outbreaks using data that was available, publicly available back in 2016. And as you can see, the P parameter really varies a lot. There's a lot of variability. There's not a clear pattern. You know, some of the respiratory pathogens tend to be closer to 1. For Ebola, we have a lot of variability. Most of the parameter values of P for Ebola are less than 1, consistent with a pathogen that is spread, that is not spread through the air. And so what is the consequence of having an epidemic that is growing sub-exponentially fast? We know that when the epidemic is growing exponentially fast, that means that the growth rate is basically constant during the early period. And as a result, R0 is well defined according to the mathematical theory of epidemics. And the reproduction number is basically equals to E to the R times the generation time, the length of the generation time, when the variance of the generation time is assumed to be fixed. So there is no variance. Or the variance is 0, actually. But if P is less than 1, then we are in a completely different landscape, terrain here, because for starters, R0 is not well defined. We follow the concept of R0 from the theory of epidemics. But actually, the reproduction number is actually a dynamic quantity, and it's actually changing over time. And it's actually declining over time asymptotically towards 1. And, you know, we prove that this quantity here is asymptotically approaching 1, which is the epidemic threshold of 1. So if the epidemic is not growing exponentially fast, we have a reproduction number is actually changing all the time. And it's actually not growing, but it's declining. And it's approaching the epidemic threshold of 1. Now, these ideas can be applied to particular specific outbreaks. Here is an example on the 2014-16 Ebola epidemic in Western area urban, where you can see on the left how the model is fitted to an increasing number of data points. Each point is a week in terms of number of cases reported in a given week. You can see that the model fits well the data, and the parameter P is much less than 1. Definitely not an exponentially growing epidemic. It's more like almost linear growth. P is around 0.5. And on the right, you see the distribution, empirical distribution of the reproduction number. On average, 1.3, has some substantial uncertainty. And you can see how the reproduction number tends to decline as we have more and more data, which is consistent with the theory, right? As the epidemic continues in this fashion, so exponentially growing, the reproduction number will tend to decline towards 1. So what are some of the mechanisms that could lead to early sub-exponential growth? I gave you already some examples. Here's an example with an spatial model with a highly constrained contact network. The top panel shows a susceptible population. The red square is one individual. In the second panel, you can see that each column corresponds to a household. So that individual interacts with another 5 individuals. And then there's another level of mixing. a group of households make up a community, okay? And the communities are overlapping with each other as well. So this individual in red then interacts with people in their own household, but also not necessarily with the same transmission rate with other households in the same community, okay? So this is an example of how that epidemic could expand over these ladders. You see the first panel are what we see during the first 21 days. In black are the infected individuals, in the gray area are susceptibles. So basically we are seeing how the virus is spreading in the form of a traveling wave outbreak, and how quickly this epidemic is traveling can be regulated by the community size, right? You can have a situation where every single household belongs to the same community, spanning all the population. In that situation, you can recover homogeneous mixing, right? So the more constrained the community size is, the more spatial signature in the spread that we will see. Here you are seeing the epidemic trajectories for this household community model when the community size is 25. So each household belongs to 25 households. And you can see how the red curve, which is the average of many stochastic realizations, follows sub-exponential growth, right? Because it's growing with this curvature, it's in log scale. And the black line is the corresponding exponentially growing epidemic that is not happening, and just shown here as a reference. The reproduction number on the right starts at 2, but then declines over time because of the sub-exponential property and approaches 1.0. Now we can move beyond the early growth to think about epidemics that are composed by the aggregation of multiple subepidemics, right? So we can think of these epidemics made of subepidemics as the aggregation of multiple underlying mechanisms, right? We can have pathogens that are spread in high-risk groups. Let's think of the MSM population or injecting drug use populations. And then from there, the virus can cascade transmission to lower and lower risk groups, heterosexual populations, for instance. Or we can think of an epidemic that is happening in multiple geographic areas, an epidemic that starts in geographic area A, and then after a while, the epidemic is seeded to geographic area B, and you have the start of a new subepidemic in such a way that when we look at the aggregated trajectory, we may be able to detect multiple peaks, multiple modes that hint at the presence of multiple subepidemics. And of course, more recently, the idea of the emergence of new variants, right? The virus is mutating, and some of the mutations may be epidemiologically important, significant, to the point that the reproduction number or some of the epidemiological properties may be changing over time. And as a result, we may see, we may investigate the overall epidemic as the aggregation of multiple subepidemics according to the variants that are circulating in the population. Here's another example. Here's an example, actual example for the Ebola epidemic in Congo in 2018, where you can see ups and downs, the fluctuations, how the virus was spreading across different administrative regions of Congo. Many of these outbreaks are linked to prior violent events. There is the attacks to treatment centers related to the response in Congo that were set to fire or that were destroyed. And so this violence actually hampered, right, which is well known, hampered the response and the possibility of containing the epidemic. It took substantial amount of time to to mitigate this epidemic, even when, you know, there were weeks, the maximum number of cases that were reported in a given week were only 140 cases. So related to this is the fact that when we have an epidemic, when an epidemic is evolving, right, we have a limited amount of data, right? In most of the situations, we have time series of the number of new cases that are reported in a given region, or by, you know, maybe by age group with, you know, some stratification. However, we don't have often more detailed information that can tell us about the transmission process, right? Who is infecting whom? Ideally, we would like to have that detailed transmission tree that could readily tell us, you know, what groups are mostly affected, tell us something about the reproduction number just by looking at the transmission tree, tell us about the frequency of super spreading events. So we often have these epidemic curves, and many different transmission trees can give rise to the same epidemic curve, right? So we have to deal with the fact that we have limited amount of information in an epidemic curve. An example of this is of an transmission tree, a real transmission tree that was characterized back in 2003 during the SARS outbreak in Singapore, right? Most of the cases occurred in healthcare settings affecting patients and healthcare workers. When we look at the epidemic curve, which is on the bottom of the transmission tree, we see a first outbreak or subepidemic that mostly affected a particular healthcare setting. And then there's a second peak or second mode, right, that is associated with transmission in another healthcare setting or healthcare settings, right? So it is only with the information about the transmission tree that we can relate these two modes of transmission, right? This outbreak is starting in a transmission setting, in a healthcare setting, and then the virus jumped through the movement of healthcare workers and patients to other healthcare settings, and then there was amplification. And so this epidemic resulted from the aggregation of multiple outbreaks, right? That at some point where the first one was independent of the second one, and shape, right, gave the form, gave the shape of this outbreak. So how can we characterize these multiple subepidemics in a rather empirical way without, you know, having to deal with the fact that some subepidemics may be influenced by some mechanism, some other subepidemics may be influenced by different mechanisms. So for start with, we can use empirical ways of doing this. And we have been, you know, successfully modeling these subepidemics or single epidemics using the logistic growth model. We call it generalized logistic growth model because we add that P parameter, right, related to the sub-exponential, the early sub-exponential growth dynamics. And so we have now three parameters. Parameter K is the epidemic size, right? So we can estimate three parameters for a given subepidemic. And at the same time, we can accommodate different early epidemic growth scaling by having this structure with a P parameter, right? Now, in order to characterize an epidemic wave, so an epidemic that is made of multiple subepidemics, we need a system of equations. This is the first subepidemic wave model that we published in BMC Medicine back in 2019, where you can see that it's basically a system of equations, differential equations. C of I corresponds to the cumulative number of cases for subepidemic I. R is the growth rate. P is the scaling over parameter, as you know. And there's this indicator variable A, uppercase A sub I minus 1, that basically allows us to connect multiple subepidemics. So A sub I of T, as a function of time, equals 1 when the current epidemic, the number of cases, the cumulative number of cases exceeds a given threshold, which is a parameter in the model called C sub THR. Whenever that cumulative number of cases for the current subepidemic that is progressing in the population exceeds that threshold, the next subepidemic takes off. So that would be C of 2. You can see in the figure, the first subepidemic is in red. The multiple red curves correspond to the uncertainty. I'll tell you in a minute about how we quantify the uncertainty. And then the blue curves correspond to the second subepidemic. And then the green one is just emerging, as you see there, is the third subepidemic, and the gray curves correspond to the aggregation of the 3 subepidemics, and the black circles are the actual data. Okay.
Hey Gerardo, can I ask a question?
Yes, please.
How does this dynamic ever go down? I mean, it's a logistic equation which typically just goes up to a certain value and stays there.
Oh, yes. When you're looking at okay, that's a great question to clarify. C of t is the cumulative, but if you take the derivative of that, that gives you a bell-shaped curve.
Okay. Okay. Thank you.
Yes. Okay. So what you're seeing here in this graph is incidence. You're right. Cumulative incidence corresponds to C of t. Yeah.
Perfect.
Okay. You're welcome. So now the parameter K sub I corresponds to the size of the subepidemic I. Okay, that's something that we need to model. So let's go to the next slide. K sub I, the size of the subepidemic I, equals this function. Basically, K naught is the size of the first subepidemic. Okay, and then the size of the subsequent subepidemics will decline exponentially fast according to this function. Q, the parameter Q, regulates how quickly the next subepidemic will be declining, right? The greater Q is, that's modeling interventions, more intense interventions or changes in behavior that mitigate transmission. And so you have epidemics, subepidemics that will tend to decline over time depending on the value of Q. If Q equals 0, the size remains the same, okay? So this is a nice function, obviously, because it has a closed form solution. And if you want to know the size of the epidemic wave, the total epidemic wave, you just need to know the size of the first subepidemic, how many subepidemics you have, which is N, and Q, that regulates interventions. So in this model, we have 3 parameters if we only have one subepidemic, right? That's the simplest model. But if we have more than one subepidemic, we just need 5 parameters. So basically it's RP, K naught, and then the threshold CTHR and parameter Q. So regardless of the numbers of epidemics that you need, you only need 5 parameters. And this is very important because then we can use the model and try to feed it to the data and be able to estimate the parameters with some reasonable amount of uncertainty, right? Because we don't want to have 100 parameters because it would be impossible to identify all those parameters. So here are some of the representative subepidemic wave profiles that you can obtain with this simple model. The first one is like a traveling wave. The second one is an epidemic wave with a very broad peak. And then if your Q is greater than 0, that means there are interventions. You can model an epidemic with a long tail. Now, if the subepidemics are weakly overlapping, so they are not too close to each other, you can actually see the subepidemic modes, right? In the 4th panel. Now, to fit the model to the data, we use a simple approach, basically use maximum likelihood or least squares to fit the model to the data for the first time and estimate these 5 parameters. And once you do that, you can add error structure to that fit. Let's say Poisson error structure or something more elaborate like over a negative binomial if you want to model over dispersion. And then to each of these realizations, you refit the parameters. And then if you do this 200 times or 300 times with the bootstrapping approach, then you will end up with an empirical distribution of each of the parameters from which you can get the point estimate and you can get the uncertainty, right? The variance of that parameter. And it's actually also nice because you actually have all of these epidemic curves for each realization, right? And you can use that envelope in the uncertainty to do a projection, to do a forecast. So you have in your hands all of the information that you need to characterize uncertainty for the current state, but also to project it into the future. Now, to assess how well the models are performing in these forecasts, there are a number of metrics. The community is converging to a set of metrics that include, the mean absolute error and the mean squared error. These measures basically only rely on the mean solution of the best fit. But if you want to incorporate uncertainty, then you can look at the coverage of the 95% prediction interval, right? Which measures how many of the data points are within your 95 prediction interval. Something more sophisticated is the mean interval score, which is related or is an elaboration, right, of the prediction interval, because now you are not only measuring how many data points are within the prediction interval, but also whether they are too far away from the prediction interval, or whether the prediction interval may be too wide, right? Because if we have a prediction interval that is too wide, it's not useful for public health authorities, right? So you need to be penalized. So the lower the mean interval score, the better the performance, okay? Here is an example of the fit of the model to the one-done data. In this example, we only needed one subepidemic to fit the data, as you can see. On the top panels, you're seeing the estimates of the parameters R, P, and K. In the bottom panel, you are seeing how the model fitted the early data points prior to the vertical line, before the vertical line. And then the forecast is on the right of the vertical line. You can see in this example how well, the uncertainty is well characterized, and many of the future data points are within this prediction interval, which is nice to have. Now, here is the example with the SARS outbreak in Singapore that I show you, that with that transmission tree of the outbreak that affected healthcare settings. It is nice to see how the subepidemic web model characterizes those two subepidemics in red and blue. Okay, so it's inferring these two peaks. So there is some information there to say something about the structure of the epidemic wave. Here's another example of the fit to the epidemic in Madagascar in 2017. The outcome here is 4 subepidemics that are strongly overlapping, as you can see here in red, blue, green, and magenta, right? Now, we can use this information, right, to generate the forecasts. So the calibration occurs prior to the vertical line. The forecasts are the next 4 weeks after the vertical line, okay? And this is a forecast for the plague outbreak that I show you. You can see how the model infers, right, the presence of more than one subepidemic, right? Even if it is not obvious, it's readily obvious to the eye, the model is inferring that there are 2 or even 3 subepidemics in some instances. And by doing that, we are getting an improved forecast, right? Because if we were modeling this with a single subepidemic, the outcome will tend to see that the epidemic will start to decline right away, right after the last calibration data point. Here are some of the performance metrics where you can see that the subepidemic web model is performing much better than simpler models that are made of one single subepidemic, such as the Richards model. And so in 2019, we quickly started to use this machinery to forecast the COVID-19 pandemic, starting with the outbreaks that were emerging from China. And then later on, we started to forecast the pandemic in the United States. And we have many of the forecasts archived on the website. Here is an example of the early forecasts for the United States. You can see that on the top, at the very early on, the model was predicting a single subepidemic. There was no more information to detect that actually this was going to get into a leveling off. It is until the third panel that you see that the model infers that there's more than one subepidemic. And you see multiple colors how the model was inferring the presence of 3 or 4 subepidemics. And by doing that, it was able to get this leveling off, right? The plateau or a slower decline, if you want, the phase of the epidemic. The subepidemic world model, perform much better than simpler models. And we're in the process of assessing how well this model not only perform better than the Richard model, but also other models, including those models that have been used by the CDC forecasting effort. Here's an example for Spain, where you can see the model, the calibration is, again, prior to the vertical line, infers 2 subepidemics, right? But it also infers a third subepidemic in green that is just starting to grow, right? And it turns out that there was a third subepidemic, or a third mode, if you want, in the Spanish epidemic curve. You can see here how it starts to emerge again, the third subepidemic. And this is the fit of the subepidemic wave model to the entire Spanish epidemic curve. It's a nice fit. The parameters are well identified. As you can see in the top panels, the uncertainty is reasonable as well. Now, more recently, we have been expanding this work to accommodate more complex, a little more complex subepidemic waves, right? Because the prior model doesn't allow you to have a resurgence period, right? After a period of stability, if you have resurgence, you will tend to have a subepidemic that overshoots the first subepidemic, right? So in order to do that, then we need to add a little bit more flexibility to the model. And now what we do is estimate a RP, the RP parameters. So assume that the R and the P are consistent across all the subepidemics, for instance. But then you need to estimate K, the size of the subepidemics for each subepidemic separately, right? So the number of model parameters is 2 plus N, where N is the number of subepidemics, times, no, sorry, just 2 plus N, okay? So these 2 is actually because we have parameter R and P, which are fixed across all the subepidemics. Here is an example with simulated data. So the data on the left, the black circles are simulated using the same model. And then the model is used to infer that shape, and infers indeed the first subepidemic in red. And then the resurgence period in blue is also detected there. And so we can use this to study the resurgence period of the COVID-19 pandemic in the United States in the summer. You can see that at the beginning, this is June 18, the model was not yet detecting the resurgence, right? But then after, 1 day later, it starts to pick up something. So that indicates that there's a subepidemic there already. And then this is June 20th, June 21st. You see the data points are within the prediction interval. The mean is a little higher than the actual data points. But overall, the uncertainty of the prediction interval is capturing the coverage of the prediction interval is good. And this is the same picture, but here I'm showing you in red and blue the 2 subepidemics. And then a few more forecasts that we have been conducting almost every week. This is the forecast that we conducted in December 1st, and the actual data points later on. So this is in real time. The red circles were placed later, and you can see that the model captured all of them. There's quite a bit of uncertainty here. There's a lot of over dispersion here. Look at the numbers. And this is during the period of the declining phase in the winter. This is for January 1st. And then the most recent periods, this is February 3rd. This is March 1st. This is March 7th, right? So you can see how the tail is actually another subepidemic. This is, the model is detecting basically two subepidemics. The first mode, which is very large here, and then the second is part of the tail. And this is, I think, one of the most recent forecasts. And so the model has been doing a nice job there. We'll see how it does in the next couple of weeks, right? Because we know that the variants, the new variants, are taking over, but at the same time, the vaccination rollout is going pretty well, right? So there's a race there. So we'll see how the model detects the resurgence and how large that resurgence is. Well, there's already a resurgence that looks more like a plateau, but then the question is whether this resurgence is actually gonna overshoot, right, that leveling off. And here's the same picture, but showing the two subepidemics. And as a way of summary, just to say that, you know, the idea, the paradigm of using subepidemics to understand the broader scale epidemic trajectories has shown a lot of promise. There's a lot of more work that needs to be done. We have been looking at other ways of connecting the model to the data, such as characterizing first the heterogeneity in the data using functional data analysis, right? Because some areas in the United States show different dynamics than others, right? Remember the first, we had the outbreaks in New York City, in the northeastern part, in California, and then later we had outbreaks in the south, and then in the mountain area, right, central part. And so if we can characterize that heterogeneity first, before we apply the subepidemic wave model to each of those clusters, and now after that, we can join the clusters into a national forecast. There's, it looks like that's improving the performance in general. How many more minutes I have, Isaac?
I would think 5-10 more minutes. So go ahead, please.
Oh, okay. Okay, good. So I'm almost there. So now the switching a little bit from, you know, mean field ensemble ideas of multi-scale models to more statistical ways of doing ensembles, what we call multimodal ensembles. So if we have multiple models, they don't have to be consistent with each other. You can have some models, you know, some could be with meta populations, with H structure. Some others could be stochastic, agent-based models, etc., etc. How do you join them together in an ensemble in the best way to generate the ensemble, right, with an improved performance metric relative to the individual models? And so in that direction, we have been doing work with Dr. Ruyan Luo, my colleague at Georgia State, and we compared two different schemes of ensembling models. The first one in the top, basically we have the models and we take the average of them based on the weights W sub I that are defined based on how well the model is fitting the data. So a model that fits very well the data tends to get higher weight than the others. And so the ensemble is the ensemble average based on those weights. In the top, and sorry, in the bottom panel, the idea is that for each data point, right? We select at random one of the models, one of the I models, right? Based on that weight. So for each data point, right, defining time, the model is selected with a probability, right, that depends basically on the weights. Okay, so it's a different way of joining the models here. And what we found is that by doing that, by actually doing that randomization, the random selection of the models for each data point, right? So for one data point, you may have model 1, for another data point, we have model 2, and then model 1, 1, 2, so forth. By doing that randomly, actually we improved the performance of the models. Here's an example. So the top panel is ensemble 1, the bottom panel is ensemble 2. This is showing an example of the performance of the generalized logistic growth model for the outbreak in Anhui, China. You can see that the ensemble 2 tends to have better coverage of the 95% confidence interval. It covers more data points in general, not only for COVID-19, but we actually applied this to many other outbreaks from Zika, COVID-19, flu, Ebola, and similar data as well. And so what we are seeing is that, you know, by using that ensemble 2, where the models are selected at random based on the weights, you get better coverage, as you can see, right? In particular, better metrics that incorporate uncertainty of the models and lower mean interval score. Here's another example with, you know, same story. But that tends to be the case not only for these 2 outbreaks, but for many others. And that's something that we reported recently in BNC medical research methodology. And well, that's it. I'd like to thank collaborators. My PhD students, actually, Kimberly and Rusa, recently joined the group of Nina Pfefferman at University of Tennessee. And I have 2 other students. Amna Tariq, my current PhD student, who is about to finish probably in 1 year or so. And Giselle Lee also contributed to the efforts. She's in Korea now, working in a public health center. And a number of collaborators that have, you know, contributed in different ways to this work. From Ruyan Luan, Georgia State, Rich Rothenberg, Kenyu Mizumoto, Kyoto University, Cecile Bibuta Fogarty, Mac Hyman, Tulane University, Maria Kiskowski and South Alabama, and Ping Yan at the Public Health Agency of Canada. Thank you very much. Any questions? Very happy to try.
Thank you very much, Gerardo, for this very interesting talk. I really enjoyed it. Colleagues, do you have any questions? Questions can either be in English or Spanish. So please just unmute your microphones and go ahead, or just write something on the chat and I can read it.
I have a question.
Go ahead, Philip.
So it seems to me like you have the machinery, at least, that could detect new variants. And I'm wondering, I guess it would be a different approach because you would have to allow R to be variable. Here it seems to me you're fixing R. You said you're fixing R and P. I think you would need to allow R to be variable, and then look for statistically significant changes in either R or K, which are 2 well-known components of fitness. It's the R-K selection. And so if you look for significant changes in one of those 2 parameters, that could be indicative of a novel strain, that with at least with a different fitness. So I saw that you mentioned the different strains at some point.
Okay, sorry, I lost the connection for a few seconds, but I'm back. And I think I got most of your question. That's great. That's a great question, comment. So yes, so let me go back to that slide related to the additional models we have trained here and subepidemic wave model, right? In this version, R and P are fixed, right?
Okay.
But you can make it even more flexible to have R and not, well, R or P or both change over during different subepidemics, right?
Okay, right.
You have to pay the price because then you need more information to make them, and maybe it depends on the data. You may have enough information, you may not have enough information. And yes, I love the idea that you raised of monitoring, right, how the growth rate could be changing over time to assess whether, oh, it looks like we may have some new variant or something different, right? It could be a new variant or it could be change behavior.
Actually, I'm not sure that P would qualify as a component of fitness. I think you're right that it may have to do more with network structure than reproductive fitness. But the real key parameters are R and K, and they're classic parameters in population genetics and evolutionary biology, and they're two different. It's R versus K selection, right? And it would be really interesting to look at those parameters for differences in those parameters in the different.
Yes, I love the idea. Yeah, you're bringing population genetics, how this can be connected to that. That's great. I would love to, if you have any references on that to get motivated, I would love to hear on those. That would be wonderful.
Sure.
But yes, monitoring those parameters and seeing how they abide to certain theories of population, genetics.
Right.
That would be interesting, right? Yeah. Thank you.
Excellent. I think Jorge, I think that Fernando had a question.
Okay, Fernando, go ahead. Yes.
And then you, Jorge, right?
Okay, I have a question also.
Hola, ¿qué tal?
Okay, so let's do the following. First Fernando, then Nancy, then Jorge, then I would like also to ask. Go ahead, Fernando, please.
Well, my question is very simple. I was just wondering if these models can incorporate underreported cases, because, for example, in Mexico, the quality of the data is not very good, and we have actually that problem of underreporting. So, how does these models can do that?
Yeah, that's a million dollar question, right? Not only for these models, but for any model. On the reporting on it's an issue, and it's an issue particularly when it's changing over time, right? Here in these models, we're saying, okay, one case represents something with some level of underreporting and some level of testing, and that's reflected in the data that is being observed. But if that underreporting is changing over time, then that can have a substantial effect on your results, and not only for these models, but for any type of model. So I think in order to accommodate on the reporting, we will need to do perhaps additional work to reconstruct something that is closer to reality before we apply these models to the signals, right? Okay. Yeah. Anyone has any clues on how to do that for the data from Mexico? Maybe Jorge, I think you have done some work with the data from Mexico.
Yeah. I have a comment. I think I will wait for the next question and then I'll go. Yeah.
Yes. Nancy, you have a question as well? Please go ahead.
Yes, please. Okay. Hi, Gerardo. Thanks Thank you. I have a question about the time delay between the two maximum or the maximum values of the sub-epidemics. So is there any relationship between this time delay or any way to measure this this interval from each maximum?
Right, the time delay between sub-epidemics, right? Like
Yeah, the maximum of the sub-epidemics, yeah.
Okay, so peak to peak, what is the distance time from one peak to the next?
Yeah, how are those related? Yeah.
Okay, they must be related to the threshold of at which the next sub-epidemic takes off. There must be a relationship. I don't have a closed form solution for that, but yeah, that's an interesting question. I haven't thought about it. The only thing that I have thought about is, if the next sub-epidemic takes off when a great fraction of the cases for the first sub-epidemic has already occurred, particularly after the peak, the modes will tend to show up in the aggregated epidemic, right? Otherwise, they are overlapping too much. I would say they are strongly overlapping. And then it looks more like a broader epidemic, right? But you don't see by eye from the aggregated trajectory the peaks, the multiple peaks characterizing multiple sub-epidemics. So yes, there must be a relationship. I don't know what that is exactly, but that's an interesting question.
Because, well, I was thinking about this, what you mentioned about the new variants. So in that case, well, if a new variant appears, how would be the time delay from one epidemic to the next? If, well, to compare to the other possible scenarios that you mentioned, that might be other circumstances. But okay, thanks.
Yes. Okay. Well, the time delay in that situation you're mentioning with the new variants, likely related to the incubation time and to the reproduction number of the new variant, perhaps in a mechanistic model with two variants. Yeah, that would be something that could be investigated.
Okay.
Yeah, thank you.
Thank you,
No,
Nancy.
thanks.
Jorge, go ahead, please.
It's a very interesting talk, and I wanted to ask the following. In Mexico, and I guess in other parts of the world, much of the social dynamics at the population level is driven by events, civic, religious, those kind of things. In Mexico, in particular, the country, as you know, we have a calendar. We were studying this, and we have a calendar that we've known all our lives, but when you look at it, it's very interesting. You have, let's start with last year when the epidemic started to create problems. We have Holy Week, then we have Children's Day, then you have 1st of May, then you have May 3rd, the day of the Albañiles, then we have May 10th, then that stopped. And we have some governmental indications of ending mitigations and so forth, but they don't have as much impact as the other. Then after June, July, August, you come to Independence Day. That is also a long weekend. And many of these things are long weekends because you have these puentes, right? And then you have the, after that, you have El Día de la Raza, then you have the holiday of the Day of the Death that starts from, if it is a weekend, it's even worse. You have 3, 4, even 5 days, depending on the year. Then in Mexico, we have this commercial thing that was the Black Friday, the equivalent in Mexico is the Buen Fin. Then after that, you have the Guadalupe Virgin Day, that is these pilgrimages that you know. Then you have Christmas, which is posadas and all the stuff. And then you end with the wise men, and then you start again. And what we have noticed, looking at the data in Mexico, even when reporting, is that all these dates present increases in positivity, in hospitalization, in mortality. And if you took a model, as some version of the Kerman-McKendrick model, you can estimate the variable effective contact rate. And you indeed see that in these dates, you have flare-ups of the rate.
Right, like pulses of amplification, right? It's like
Right.
you have a pulse, and then for brief period of time.
In these periods, and you can see that in the data. It depends on how long is the super spreading event. You can have the jump in all these indicators immediately afterwards, or even within the period, because of the disease, the nature of the disease. Then we are using this historical evidence, because even, and you can even predict things, because this year in Mexico is federal election. So you know that on 6th June is going to be Q's, and before campaigns that start someday soon, or even started probably, I don't know. But then you can have, and you can, my bet, or many people's bet actually, is these are the super spreading events that are going to continue to move the epidemic in the countries that have very mild control mitigation strategies. And also these events are, that's intuition, is where more likely the new mutants, if they exist in Mexico, will spread faster and will be the initiation of many of these events. The problem is, it sounds reasonable, but the problem is where will it start, right? But that is another question. And I'm looking at we have this model. We have the historical evolution of the epidemic. Last year, we have fitted our model. We have what you have to do to fit the model, but for the predictions, instead of making a forward prediction with some statistical technique, we take the basic the effective reproductive rate that we computed last year. We have the history, and say the jumps in the effective contact rate will be more or less the same, but it's not going to be the same scenario, because we have a depletion of the number of susceptibles, and our RT last year was most of the year around 1. Now we've been like 2 months, like around 0.8. So it's not going to have the same effect, but they will be super spreading events. And I was wondering, looking at these multiple epidemics, if that technique could be used to improve these scenarios, because we only do we cut our estimation of parameters and model fitting to February, and then looking at the changes on the contact rate, possible changes because of this Holy Week and these things, we increase or not the reproductive number and the contact rate. But probably with these methods, you can have a more systematic way. And the question, I mean, long example, but the question is, have you worked or know about work that are using these key calendar dates as indicators of super spreading for the prediction of epidemics? I don't know. It's a question.
Great. Not that on top of my head. No. That's interesting. So you're saying we have this historical data with these properties. Now we can use it, right, to predict.
Because they are periodic, right?
Indeed.
They repeat every year, and you can in advance, if it's going to be a long weekend or only an isolated day, or you can do many things because you know what is going to happen, because our calendar days, right?
Right.
And if you assume that the changes in the contact rate will be more or less the same, you have a way of not forecasting, to making projections.
Yes. So I would take that information as additional information to what we have, right? That would provide additional information that could tell us, that we could say, based on this, I expect new subepidemics with different growth rates, right? And different sizes around these periods of time. And then you roughly define where you expect the subepidemics to occur, or the changes in the subepidemics, right?
Yeah.
And then
the magnitude, right?
The magnitude, the growth rate.
Right.
I would look at the relative changes, right? You said reproduction number?
Right. No, we measure the effective, the instantaneous reproductive number, and the contact rate, because then the number of susceptibles is very hard. In Mexico, we cannot do it. We don't do testing. We don't have anything. But that is a parameter that is really the problem. How many susceptibles are still available for infection, given the history of the epidemic and the fact that we have temporal immunity, and now what Phil was saying, the new variants, right? Well, that was broadly what I was thinking.
So that's, yeah, that you're saying there is more information that could be used, and that most likely will help you improve.
Right. You don't have to rely only on the statistical methods. It's you have to, right? But, but there we have a history of a year in a country like Mexico, where these religious and civic days are really places where the people go out with the family or with whatever things. These are super spreading events by definition, and we can't predict when they are going to occur and how long they are going to be.
So I would use that to do, as you said, right? Not only short term, but try to project longer term based on that information. How the subepidemic will shape up the summer, for instance, the summer in Mexico.
Yeah, yeah. I will send you the preprint, so you can.
That would be great. Maybe
we can
collaborate on. Okay.
Right. Exactly. Okay. Yeah. Thank you, Gerardo. Thank you.
Thank you, Jorge.
There is a question in the chat from Eric Avila in Spanish, so I'll read in Spanish. Dice Eric, o pregunta Eric, ¿podemos incorporar en estos N subepidemic wave models vacunas, estructura de edades, etcétera, etcétera?
Yes. In this particular structure, en este tipo de modelo que presenté, no está listo para hacerlo, pero sí se podría utilizar en el contexto del clásico SIR, ¿no? Modelo SIR. Entonces, en vez de tener el General Growth Model como una subepidemia, ahora un SIR, ¿sí? Corresponde a como una metapoblación corresponde a una subepidemia. La diferencia con un metapopulation model como el que conocemos en la literatura es que en este contexto la siguiente subepidemia empieza a crecer una vez que el número cumulativo de casos llega a cierto threshold. Esa es la diferencia fundamental entre el clásico metapopulation model, donde tienen migración, rates, que son parámetros con tiempo, versus este tipo de framework. Y sí he estado echándole una pensada de cómo se puede incorporar. Y una vez que tienes el SIR, pues sí se podría agregar más detalle, ¿no? Como vacunación, como dices tú, o más refinación en términos de los grupos de transmisión, grupos etarios, etc.
Sí.
No tengo referencia específicamente, pero lo que te digo es algo que es básicamente lo que presenté, pero ahora este parámetro, déjame regresar el slide donde, acá. Este parámetro C sub THR, CTHR, que es como un threshold, se define. Entonces, una vez que el número de casos en tu SIR alcanza cierto valor, el cumulativo, eso triggers, ¿verdad? Inicia el crecimiento del siguiente epidemia, lo cual modelarás con otro SIR, con otro grupo, ¿no? Entonces hay que decidir ahí ya los R0 cómo están relacionados entre ellos, los tamaños de la población, si los tamaños van a ser definidos más o menos constante, la N, por ejemplo. Pero sí, he estado echando una pensada de repente y podría haber algo ahí. Con gusto podría estar en contacto con Eric sobre eso.
Fantástico. Si me envías a mí la información, se la puedo enviar a Eric. Muchas gracias. Creo que Gerardo tiene una reunión y se va a ir. Yo tenía preguntas, solo voy a hacer una porque ya nos hemos pasado un poquito de tiempo, si me permites, Gerardo, es de carácter técnico. Y algo que comentar, si nosotros, de hecho, con mi grupo que estamos trabajando en cosas de epidemiología, también estamos trabajando en un tipo de approach donde consideramos un número infinito un universo infinito de posibles modelos para fitear datos, utilizando técnicas de redes neuronales para resolver ecuaciones diferenciales. Pero te quería hacer una pregunta de la última parte que explicaste, de los dos ensambles. Me preguntaba si de alguna forma los pesos tienen en cuenta la complejidad del modelo que estás utilizando para fitear los datos. Porque claramente si, como dices que puedes utilizar modelos diferentes, incluso mecanismos, incluso en contextos, técnicas muy diferentes, cada modelo tiene una complejidad y de alguna forma se tiene que capturar en los pesos. ¿Eso lo hacéis?
Se puede hacer. En este paper que publicamos utilizamos el mean square error, pero sabes que se podría utilizar el AIC.
Claro.
AIC y ahí te incorpora información sobre el número de parámetros asociado con el modelo que estás utilizando, ¿verdad? Eso es más o menos lo que tienes en mente.
Sí, de alguna forma, porque si tú utilizas modelos con muchos parámetros, entonces el fit te va a quedar mejor, pero tienes que penalizar porque tienes más parámetros y eso te va a incrementar la incertidumbre asociada a ese modelo. ¿Okay? De tal forma, cuando estés haciendo, de alguna forma estáis pensando los modelos de la misma forma, bueno, teniendo en cuenta, por ejemplo, el likelihood, pero no tenés en cuenta la complejidad del modelo. También una cosita, me sorprende un poquito porque que los dos ensambles te den resultados diferentes, porque la intuición al principio dictaría que deberían ser equivalentes los dos ensambles. ¿Cómo lo hacéis? ¿No?
Exacto, ese es un buen punto. De hecho, en el paper mostramos que la varianza del segundo es mayor, la varianza del ensamble, y damos la expresión. No es difícil. Te puedo mostrar la expresión de que está, no la puse en la presentación, pero te la puedo presentar ahora mismo en un segundo.
O si quieres me puedes enviar el paper y lo discutimos.
Te envío.
¿Sí? Para no
Sí. Está te envío el paper. Y sí, la diferencia es la varianza. Tiene mayor varianza en el segundo ensamblaje que en el primero. Y eso es lo que te permite, te ayuda a capturar más puntos.
Ya, pero creo que es intuitivo, porque entonces la segunda era tiempo de Poisson, ¿no? Lo generas de forma Poissoniana en el tiempo, ¿verdad?
Sí, el error es Poisson, es cierto.
Ok, ya veo. Bueno, pues...
Otra pregunta rápido.
Otra pregunta rápida, Philip, porque ya nos estamos pasando un poquito de tiempo. Adelante, Philip, por favor.
I just had another thought about evolution and the parameter p, and I wanted to get your thought on this idea. So, my thought is that if p should be inversely related to the strength of selection, because if you have a smaller p, then the strains, the contexts are, well, the different potential strains are in closer contact with each other. If that makes sense, right? They're more directly, they're more in
more mixing, more interbreeding.
They're more in direct contact with each other. So
interesting. Okay.
Anyways, that's just the thought.
Something I love to reconnect with you, Philip, because then you have these ideas from population genetics that can help us refine this.
Yeah. I think there might be a nice approach here to look for a way to detect novel strains and that sort of thing.
That would be very cool. Yeah, statistically and all that. Okay, I would love to. Yeah, maybe if you can send me a reference or two, Philip, maybe we can start from there and start a conversation.
Yeah.
And nice to see you too. Yeah.
Okay. Yeah.
So very good, guys. Well, Gerardo, thank you very much for this very interesting talk. I really enjoyed it. I think everybody did. So we thank you, for visiting us virtually in Mexico City and for giving this talk. And colleagues, just to remind you that in 2 weeks we'll have the next seminar. It will be given by a colleague of us from Mexico City, Ivan Santa Maria Oleg. I don't have the information yet, but I'll send it soon. Okay. Once again, Gerardo, thank you very much. Thank you, guys. See you in 2 weeks. Bye bye.
Thank you very much. Bye-bye.
Hey.